I get the point of this soon. So basically, we're going to review the two conditions. In both, we're going to really kind of talk about sort of what, why these conditions, which you might not have really thought a lot about, are important to think about, especially with certain types of EB. These complications are really most pertinent to patients who either have recessive dystrophic EB or junctional EB. But we're going to sort of think about, again, why they happen, and then what can you really sort of do in terms of preventing them or minimizing the risk for them, and also treating them. And as I had mentioned, I brought this up in the first talk, but it's important to reiterate again that, that EB is not just a skin disorder. We see complications in other organ systems. It's important to sort of think about the whole patient. And these complications need to be addressed as well as part of your ongoing care. So we're going to start with anemia. What exactly is anemia? So anemia is a condition where your body does not have enough healthy red blood cells. And our red blood cells are really important because they are the cells that provide oxygen to our body tissues. Within those little red blood cells, those are the cells that sort of look like little red donuts in our blood, there is a molecule called hemoglobin, and the hemoglobin is made from iron. It basically sort of holds onto the oxygen and brings it to our tissues. The red blood cells are made in our bone marrow, and in terms of other factors that help us, there's a hormone made in our kidneys called erythropoietin that actually stimulates our bone marrow to make more red blood cells. So you can see that there's sort of different parts of this system. So what causes anemia? There are many different types of anemia. There are certain forms of anemia that are genetically inherited, like sickle cell disease. You can become anemic because of blood loss. So this is what happens if you've had like a traumatic injury. You lose a lot of blood, you're anemic. But probably, what we're more commonly dealing with in EB is a combination of iron deficiency and also what is now called the anemia of inflammation, or what used to sometimes be called the anemia of chronic disease. So in iron deficiency, this can result from a couple factors. Number one being that you're just not getting enough iron in your diet, or number two, that you're losing iron at an increased rate. And then we'll talk, actually we're going to talk a little bit more about these mechanisms. So a really kind of easy or simplistic way to kind of think about this is that if you just kind of think about, teeter-totter in regards to sort of how we use iron in our body. We have iron intake, basically coming from our foods, from our dietary supplements, and then we have iron, we all basically lose iron. We can lose it through our skin, we can also lose it through our guts, but basically our normal kind of physiology kind of balances, kind of what we need and what we lose, ideally. But what happens when you have iron deficiency, this can really kind of, it's an imbalance basically between that iron intake and iron loss. And it can either result from, again, you're not getting enough, you might not be eating a diet that's rich enough in iron, or, in the case of EB, it might just be really hard for you to eat foods that are rich in iron. And so actually I think that this last talk about blenderized diets was great because, this is really kind of a way to think about how you actually could, improve your intake of foods that are rich in iron, basically meats. I mean, it's hard for patients with EB to actually chew their meats efficiently or to swallow them, especially if they have strictures. So, I thought that, this talk about the blenderized diets was great because this is kind of a way that we might be able to address this outside of, giving lots of dietary supplements. But the other kind of side of that being, kind of out of balance is that you might also have increased iron losses because of problems such as bleeding, wounds, bleeding, or losses through the GI tract. In terms of the anemia of inflammation, the role that inflammation plays in the development of anemia is more or less that the inflammation interferes with our body's ability to absorb iron efficiently, and it also interferes with our body's ability to really kind of use the iron that we have appropriately. So again, the anemia of inflammation really kind of skews us to a picture that kind of looks like that we're iron deficient, even if we are getting enough iron in our diet. And inflammation, I mean, I guess may or may not be something that you think about with EB, but really, when we look at inflammatory markers in patients who have EB, their inflammatory markers are often very, very high. And we think that this is probably because of wound healing, colonization of the wounds with bacteria, that basically that kind of leaves the body sort of in this chronically sort of inflamed state. And again, that inflammation is what makes it difficult for you to use your iron efficiently. So when should we be thinking, about anemia in a patient? You could certainly, think about symptoms. The symptoms that you might see include feeling tired all the time or just kind of having a lack of energy. Anemia can also contribute to an inability of the wounds to heal very well. So just because they're kind of not, again, getting enough oxygenation. And signs that you might see, might include that you might look pale, the lips are not going to look very red, the inside of the eyes might not look very red. In more chronic forms of anemia, symptoms can include hair loss, rapid heartbeat, heart murmur that the doctor might hear on physical examination, or even low blood pressure. One thing that I wanted to kind of mention to you is that, these symptoms can sometimes be hard to pick up on. So if, for example, in the case where, let's say you were in an accident and you lost blood, that's a pretty rapid change from where you kind of were normally to getting to be anemic. And so the symptoms really are pretty dramatic. They're easy to pick up on. But in the case of many children with chronic diseases, these symptoms will sort of slowly develop over time. And there's this phenomenon called accommodation, where you sort of get used to how you feel, so you don't think that there's something wrong. And I think that this is often kind of, what we see in EB, that, well, yeah, I feel a little bit tired, but maybe I just had a bad day, and it doesn't really kind of, it isn't something that people sort of, necessarily pick up on as being something abnormal. So this kind of brings us to, our role for, how do we kind of diagnose anemia? It really needs to be done based on blood testing, and that could be, done because you feel like you have symptoms. But I think that there is also a role for routine screening tests for certain patients with EB. Again, because, you might not be aware of whether or not you're symptomatic. We've definitely had some people come in saying, I'm feeling like I normally do, but lo and behold, when you check their labs, they're anemic, and then when you treat that, it does make a difference for them. So, what it really is the optimal frequency of testing, nobody knows. We sort of have guidelines kind of based on clinical experience, but they haven't really been tested to see, whether or not this is really optimal. But this is sort of, kind of generally what we're looking at: blood counts, iron levels, and, again, how often it could be done kind of depends on the situation. So what really is normal? Normal kind of depends on whether or not you're male or female. It also depends on your age. The values that I have listed here for hemoglobin are for adults. In kids, the levels are going to be a little bit lower, but do vary based on age. So exactly, how common is anemia in patients with EB? And I would have to just say that kind of based on my clinical experience, I do think it's very common. Data from the EB registry suggested that probably at least 50% of patients with RDEB had anemia. But the data doesn't really kind of go beyond that in terms of describing the scope of the problem. What I have listed here, some of you, I know, go to be treated at EB centers, and you might have been asked to participate in this database called the Epidermolysis Bullosa Clinical Research Consortium database, or Clinical Outcomes database. And that basically is a database that has been set up between several EB centers. All the data is actually housed at Stanford, but what we are basically doing is that when patients come in to see their doctors, if they have lab tests, all of that information is entered into this database, with the idea that we can then look at that to kind of get a better sense of kind of what is the scope of different clinical complications that we're seeing, to become, more familiar with how we might actually treat those complications better and then follow those patients over time. So we, about a year ago, had kind of collected a group of, or data from about 104 patients in the database who had at least one blood count during the study time period. And so of those 104 patients with recessive dystrophic EB, we saw that the average hemoglobin level was about 10.7. but that the range of hemoglobin was anywhere from about 5.8 to 15.5. So again, this kind of speaks to a range of severity. This is not stratified or filtered at all to look at effects of treatment. You know, you can see here though that there are some people who tend to get very, very anemic. I mean, 5.8 is pretty much, it's really bad. You know, whereas 15.5 is you know, again, kind of in that normal range for adults. So there is, again, kind of this range of severity that we see, and it probably does correlate with disease severity. So how can you prevent being anemic? As we've alluded to, you know, including iron-rich foods in your diet is really important. Taking, you know, vitamin supplements, optimizing your wound healing so that there is less bleeding, less inflammation going on. In terms of the DEXA scan, I mean, the DEXA scan does have some limitations. You know, it kind of gives you a value for bone density, but it does not diagnose fractures. If you have a child who develops acute onset of pain, especially if it's back pain, that needs to be evaluated with an X-ray. So that's important to keep in mind. And then there are this whole class of medications called bisphosphonates. You know, these are the medications, again, that you might have seen in commercials that are, again, targeted more for women, for postmenopausal women. They're medications that help to prevent bone loss. And these can be used in children with osteopenia or osteoporosis who have had fractures, but I think that, you know, their role just in terms of treating low bone density at this point is very, very unclear. And that would certainly be something that we would not recommend outside of a research study. All right, so that brings me to the end of that portion. Again, I'd like to thank, you know, all of our patients and families. You know, many of you have been kind enough to volunteer to participate in some of these studies that I've described. You know, the work that I've done here was mainly done at Lucille Packard Children's Hospital and also here at Children's Hospital in Colorado. And the funding, you know, for these projects has included the Dermatology Foundation, EBMRF, and again, the Jackson Gabriel Silver Foundation. So thank you very much. I'm happy to take any questions if there are any.